Hey guys, I'm sorry that I'm a little bit late. I guess I got confused with Central versus Eastern time. Um, okay, I am just getting used to this. This is the first time I have done live through a page that's not my own. Okay, so just to start out, my name is Danielle Houston, and I am a registered dietitian. I'm also licensed in the state of Texas. I've been specializing in bariatrics for about the past 5 years. So we're going to just talk about some of my experience, what I like, what I've encountered, what I do, what I don't like, how I got here, all of that for about the next half an hour. If there's any questions that come in, I'll definitely try to answer all of those. If you want to connect with me on social media, I am on LinkedIn for a professional platform. I have Facebook and Instagram, but they are personal accounts, which is fine. You're welcome to connect on there as well. But they're my personal accounts. I don't have, I've not started any professional pages. So I kind of decided to get into dietetics in a weird way. The first 2 years of college, I was actually a pharmacy major, but I wasn't passionate about it. So then one day a friend just suggested to me that I might look into nutrition because I was like always reading food labels and just interested in nutrition and exercise in general. I did feel like I struggled with my weight probably since about the 5th grade. And so that kind of led to some of my, looking at nutrition and all of that. And so I met with my college guidance counselor and decided to go ahead and switch to dietetics as a major. I chose that as opposed to nutrition. You can get a bachelor's degree in nutrition, but I wanted to really work with people. And so obviously looking to be a registered dietitian as a path with that degree is very much people focused. Nutrition seemed to be more science, lab based, maybe work for a food company, and that didn't interest me as much. So I graduated from the University of Arizona, which is in Tucson, Arizona, in 2008 with my bachelor's degree. But I did struggle to get accepted into an internship, which I know is very common for a lot of people. So I actually spent 5 years doing other various jobs. I did become a dietetic technician registered, and I had a couple of different jobs. Some were in food service and some were on the clinical side, helping out the dietitians, seeing the lower acuity patients, referring back to them. So by the time I got my internship, I was very comprehensive that I've done both food service and clinical, which worked out to my benefit. I completed my internship at Texas Health Presbyterian Hospital in Dallas in 2014, and I passed my RD exam a month later, and I took the first job that was offered to me because you have no income for a whole year, and so somebody wanted to hire me, and I was more than happy to do that. But that job has been the reason that my career has gone so well and that I got into bariatrics. So if you're in that position going to be a dietitian and you think, man, I should be selective or picky, it worked out well for me that I took the first thing that came at me. I was actually hired by Sodexo to work at a small community hospital that's in East Dallas. And while it was small, they had a fantastic ICU and they cared for very sick patients there. There was only one other dietitian at that hospital, and she had a wealth of experience. So I learned a lot in just 1 year working with her. She encouraged me to reach out to doctors to discuss my recommendations, which can be very intimidating when you're new. It's like easier to sit behind the computer and type and hope that they read your notes, which is not going to happen. But I believe this is really what led me to excel now in my specialty of bariatrics, because you can't be shy in this specialty. So she really helped me overcome some of that. And then this particular hospital, it had 2 different outpatient programs, cardiac rehab and then a bariatric surgery clinic. And since I was the new person, I was assigned bariatrics because my coworker preferred cardiac rehab. So no, bariatrics wasn't something I planned as a specialty. It just kind of fell into my lap. At first, I would go to that clinic maybe 2 to 4 hours per week out of my 40, and the rest of the time I spent doing inpatient assessments. They didn't have a very big patient population when I started, and I was told that my job was to simply do pre-op nutrition consults as they were ordered. In bariatrics, we follow two guidelines. One is what the insurance company requires in order for a patient to be approved for surgery, and the other is what the surgeon requires. Most patients will consult with a dietitian 2 to 6 times before their surgery, just based on those guidelines. They had 3 surgeons who were using the clinic at that time. I actually only met one of those surgeons at first, and it was a big test for me. So yes, I was new as a dietitian, but I did have a wealth of experience from all those years spent as a diet tech and working alongside dietitians. So I was maybe a little bit more confident than some new dietitians would be. So this particular surgeon, when he met me, challenged me the very first time I was introduced to him. He said to me, "What makes you qualified to see my patients?" And I was shaking inside, but I looked him straight in the eye and said, "Well, sir, I am a registered dietitian and I am passionate about this patient population. I have learned your curriculum and will teach your patients with this material, as well as any research of the Academy of Nutrition and Dietetics. However, if a patient gives you any feedback about myself or our sessions and you would like to discuss it with me, I will be more than willing." And to this day, I'm so proud that I didn't back down or be intimidated by that person, but I was also respectful. So now that I've been working in bariatrics full time for about 5 years, I've realized this type of situation occurs frequently, but by displaying confidence, knowledge, and respect is the way to get the surgeons on your side. And believe me, in this specialty, you need good working relationships with them. So that's key in bariatrics. I worked at that hospital doing part-time inpatient care, part-time bariatrics for about a year. And then at that time, the bariatric coordinator, who was a nurse, left her position, and the department had been restructured. So there was another nurse working there who was the manager, basically. And so something kind of important to learn if you're interested in bariatrics or assigned to it is the role of MBSAQIP, which stands for Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. So this hospital was accredited by MBSAQIP, so they're required to have certain roles to fill. Mainly, it's a bariatric coordinator, a clinical reviewer, and a medical director. And MBSAQIP changed their guidelines maybe 8 to 10 years ago so that either a registered nurse or registered dietitian can fill the role of coordinator, which is very unique. So the manager of that program, who was also the clinical reviewer, she offered me the role of coordinator, and I took it. And she had a lot of faith in me, even though I'd only been doing the dietitian part, and that was a big jump of a job, and I had no experience in it. She really kind of nurtured that in me, and this role is really what provided my foundation for everything I've done since then. So she taught me all about the MBSAQIP standards and that it was our job to enforce them. Many surgeons don't know these standards, so you often have to talk to them or their offices about the standards, but from the hospital side, it's usually about why they can't operate on someone at your hospital, which any of you who work with doctors or surgeons in particular can see how well that would go over when you say, "I'm sorry, you can't do this case here." So yes, as a bariatric dietitian, if you take a role like coordinator, you will have to go toe-to-toe with these doctors, but you're not making up the rules. It's not just, hey, we don't like you, we're enforcing this rule. It's literally your job. These rules are set forth by MBSAQIP, and as the coordinator, it's your job to enforce them, because if you don't, you will lose your accreditation. I'll talk more about MBSAQIP later if we have time or people have questions. So I was the coordinator of that program for about 2 years. It was fairly high volume, averaging at least 200 surgery cases per year. The hospital also owned and ran their own bariatric clinic. So once myself and my boss were in place, we were able to increase the patient volume there. So basically, I had to be in charge of 2 components. One, the inpatient hospital side, and 2 was the outpatient clinic. Of the two, I can tell you that running a clinic is the more time-consuming and challenging part, as you are responsible for the patient's care, both before and after surgery. It's not just, hey, they're in the hospital, they're my patient. They are your patient from the time they set foot in that clinic to forever after surgery, because bariatrics is forever. We don't just stop seeing our patients. So I wasn't just the dietitian in this role. I was in charge of the clinic, which means aside from seeing patients before and after surgery as a dietitian, I also ran the clinics for each surgeon when they came in to see patients. And we had 5 different surgeons there, which means 5 different protocols, 5 different ways of wanting to do things. And luckily, I'm very good where I can space my brain out. So when it was this surgeon's time, I knew he wanted this, did not want this. This is what he usually ordered. This is how he liked to be talked to. Could you joke around with him? Could you not? All of those things are really important. And then I would also send out and follow up on all the referrals that were ordered by the surgeon. So usually patients will have to do pre-op psych clearance, cardiac clearance, EGD scope, sometimes other things. So I had to fax out all those referrals and then make sure the patient got scheduled and get the report back. So then once they were ready for surgery, I submitted their case to insurance for approval, and then I scheduled the surgery at the hospital, and then it would switch foot to, okay, now they were an inpatient. I would see them inpatient, chart on them inpatient, schedule their follow-up in the clinic. So those two pieces, they flow together, but it's very time consuming. So as we built up the volume, the duties of the clinic became very stressful with time, and they eventually hired a medical assistant to help me. And then in that clinic, we also had a full-time secretary / patient coordinator and a full-time insurance verification position. So really that position is what taught me everything I know about bariatrics, and is the reason I can now move to different jobs within that specialty and be very useful. A lot of sorry, I lost my train of thought there for a second. A lot of dietitians, they might specialize in bariatrics, but they haven't been given that opportunity to be as involved in NBSA QIP, run a clinic, things like that. And so as much work as it was, that foundation is always there. Yes, the rules change sometimes, but it's all kind of the same. There was a question that popped up about, has our caseload increased since the pandemic, which a lot of people do ask, because everybody has seen that there's a big tie between COVID and obesity, and that maybe your outcomes are going to be worse if you catch COVID and you have obesity. So I wouldn't say that caseload has increased between my current job, and then I also work part-time for another bariatric consulting company. I didn't see an increase necessarily in patients, but I did have a lot of patients who I was talking to, counseling with, that would talk about that. Normally patients come through and it's, I have diabetes, I have hypertension, I'm not comfortable, I have joint issues. And so that would come up more like, man, I really hope I can get this surgery soon because I'm afraid of COVID. And if I catch it and I'm morbidly obese, that's going to be worse. Whereas if I can get surgery and even drop 50 pounds in the next 2 months, and then I got COVID, God forbid, maybe my outcomes would be better. So yes, in that sort of case, but I'm not really in a position right now where I was tracking numbers. So I didn't see an increase. What happens in bariatrics that everybody who works in the field knows, you're pretty slow as doctors and as dietitians with patients, maybe the first 4 to 5 months of the year. And then the middle section of the year, you start to pick up volume. October, November, December are going to be your busiest months, because people have met their deductible and out of pocket, and all of a sudden they go, I can have free surgery. So we get a lot of cases at that point. Surgeons are trying to fit them in at the end. So from the hospital side, this facility that I'm working at did, I think, 105 bariatric surgeries just in December alone. So yes, that kind of got off on a sidetrack there. So I decided to leave that position where I ran that clinic and was the coordinator. mostly due to the fact that the company was unwilling to compensate me fairly given the increase in my duties. Clearly, it changed so much from being hired as a brand new dietitian to being an important part of keeping that program and the accreditation, and nobody was willing to increase my compensation. So I decided to take a newly open position as a practice manager for two of the surgeons that I had been working with in that clinic. So all of our surgeons, when you're a hospital-based clinic, obviously they all own their private practices. So they took me on as their practice manager. I felt like with my experience, I was ready to move up and be the boss. So I worked at that job for almost a year and a half, and it was really beneficial for me to learn the private practice side since I had all the insight from the hospital side already. Now, working for two people who own a company is very different than working for a large company, and the demands of the job made it less enjoyable. And additionally, I wasn't able to do much in terms of using my dietitian credential because I couldn't bill my services to insurance. That's something that I learned when you work at the hospital. You bill under their NPI. And so, of course, they're in network with like everything. So you're in network with everything. But once you're on the private side, you have to get credentialed. Dietitians can get MPIs, which I have now. And you can get credentialed. You have to do them separately. I want to be credentialed with Aetna, Cigna, Blue Cross, United Healthcare, etc. So since nobody there had the knowledge or time to do that, I really didn't see patients because who would want to pay out of pocket for my services when they could go to a dietitian who's credentialed and get it billed to their insurance. So managing a small company like that, it takes a very specific personality. That's what I learned. And I'm very proud of what I accomplished there. The office was pretty disorganized when I stepped in, and I put a lot of protocols and procedures in place so that when I left, things were much smoother and patient satisfaction was much higher. And, you know, it's kind of a lesson. You definitely don't want to burn bridges with anybody because I still work with those surgeons in my hospital position, and they understood why I was leaving, and I gave them time and taught the new person, so we still have a good relationship. So now I work for a large hospital and national company. I'm still in Dallas. I've worked for this company. They have multiple campuses, and I've been at a couple of different campuses since July of 2019. The current campus I'm at has a high volume inpatient surgery program, which did over 300 surgeries in 2020. The bariatric coordinator and nurse has been here for about a year and had to do some work to improve the program. And together, she and I have some great plans to make this a premier center for bariatrics. And it just so happens that this nurse is the same person who first gave me that chance to be the coordinator all those years ago. So this is something I cannot stress enough. In bariatrics, connections and reputation are everything. The DFW Metroplex is massive, and yet those of us in bariatrics know each other, whether it's through social media, paperwork, jobs, anything. We've heard of each other. So you really have to guard your reputation so that when you do move positions, you're someone that people know and like and want to work with. I've had surgeons who followed me through my jobs because they trust me and want me to care for their patients. And it's taken time, but knowing that I've gained the trust and respect of numerous surgeons in this area is something that I am very proud of. So at my current facility, we have about 10 surgeons on staff. They perform everything from, lap band removal, sleeves, conversions of like a band to a bypass, revisions of previous surgeries. Some of them use the robot, so they're doing them robotically and laparoscopically. This hospital doesn't have a clinic. So right now I'm focusing on inpatient care, also helping with data entry because that's one of the parts of being accredited. All patients have to be placed into a registry and have strict follow-up requirements. And then we're getting me started on seeing patients before and after surgery through an outpatient counseling through the hospital. I've only been back from maternity leave and at this hospital for about a week. So we've made a lot of progress in a week actually, but I'm not quite doing that yet. I do see all inpatient bariatrics, which includes patients who are here for just 1 or 2 days after surgery, as well as patients who are readmitted after surgery. We do see some complications. Patients come back for things like dehydration, nausea, vomiting, bowel obstructions, and then of course you get some that are malnourished. Usually we're seeing protein malnutrition as opposed to total malnutrition. The surgeons trust me to care for these patients, and I do write TPN and tube feeding orders for them. So a little bit more about MBSA QIP and their accreditation. They do come and they do a site survey and review your program every 3 years. And I have been through one of these surveys, and it was when I was the coordinator of the program, and it is very intense. So if you end up taking one of these positions, be prepared. They come for a whole day, and they send a surgeon who is actively a practicing bariatric surgeon. They come and review the whole program. The first half of the day, they spend reviewing charts. So the clinical reviewer, the coordinator, and the medical director are the only people who are allowed in the room. You have certain charts that are required to be reviewed, such as mortality, length of stay greater than 7 days, readmit within 30 days, and although these are patients from lots of different surgeons, the medical director is required to answer questions about their care. At lunch, all the surgeons, as well as the adjunct staff, so like your psychiatrist, psychologist, dietitian, whoever, are expected to come, and you have an informal roundtable with them. And then in the afternoon, they go on a tour, usually like your ER, your ICU, your OR. You're required to have a dedicated post-op unit for your bariatric patients. And then he'll review all the standards, which off the top of my head, I can't tell you how many standards they are, but you know, the concept is fairly simple. You have a book of standards. You have to meet each one. It tells you what the standard is, why it's there, and it tells you exactly how you can meet it. So the concept is simple. Meeting those, not always so simple, especially when you have all these different surgeons and you kind of have to, that's why it takes more than one person to run these programs, because there's way too much work to do for just one person, especially at a high volume like this. So it took myself and my boss about a year to prepare for that survey, but when that day came, we were ready and it was perfect. So you have to remember that this program is about quality. That's what it always will come back to. We want good and safe outcomes for our patients. And then they do have, you can be accredited with as an adolescent center as well, which this current hospital I'm at is. I haven't seen any adolescent patients myself. That would be anybody under 18, just because I'm new here. Let me check in on our questions before I keep going. So some of the health benefits that we would see in our patients after surgery. You get some patients who are just morbidly obese, have a BMI over 40. That usually qualifies them for surgery. And really, they don't have anything else going on. There's a good percentage of those patients. But most of our patients will have a BMI over 35. The highest that I have done at one of my hospitals, I believe, is a BMI of 99. And so generally those patients will also have hypertension, very common, usually on multiple medications, high cholesterol on a statin generally. A lot of them have obstructive sleep apnea requiring a CPAP or a BiPAP. A lot of them have that and don't know it. So we generally will send them for a sleep study if they've never had one or been diagnosed. Diabetes, extremely common in our patients, generally a type 2. I have had some type 1s. Most of my type 2s, I would say at least 80% of them are requiring insulin by the time they get to me. And then you'll get joint replacements, people who are almost immobile. And then this facility has a robust transplant program. So we will have patients coming to us for bariatric surgery because they're in end-stage renal or end-stage heart, and they have to lose weight to get on the transplant list for that. So we track all these metrics in the database, and after surgery, probably the two biggest that we see resolve the most quickly would be blood pressure and diabetes. Sometimes patients their blood pressure will come down between their pre-op diet where they lose weight and just a few days after surgery where they might be in the hospital. to the point where the doctor doesn't want them taking their blood pressure med or the full pill because they're afraid it's going to drop them too low. So they'll tell them to take half, or they have to monitor their pressure, and they'll give them a threshold. If you're at this or above, then go ahead and take your medication. Of course, when our patients are on insulin, we have to teach them to closely monitor those blood sugars because, a lot of them, surprisingly, perhaps, they don't check their sugars. They just give themselves their normal doses of things. And I'm like, you can't do that because suddenly you're going to drop. You inject yourself with insulin when your blood sugar is already 100. Now you're going to have to end up in the ER. So we're real careful about that because we do see that resolve quite quickly. I don't know all the mechanisms about that. The bypass has been proven to have the greatest impact on resolving diabetes. And I'm not the right person to speak about why that may be. But we do see that, people are like, oh no, I'm going to have to take these meds for another year. And some of our patients, at their 3-month follow-up, they're off of everything. So it's amazing. Aside from the weight loss, which people love, of course, when you have these patients with these comorbidities, seeing them, they'll be in tears over the fact that they don't have to stick themselves anymore. They're saving money on medications. I've had people who couldn't believe that they could tie their shoe, bend over and tie their shoe. So that's probably the most rewarding thing about working in this field. Yes, you have people who are non-compliant. Yes, they have horrible eating habits before surgery. They may go back to some of those habits even after surgery. But seeing them almost become a new person, and to have them crying in your office and they tell you that you saved their life, that's something, that was the piece I was looking for that I never really got when I worked inpatient. So when it comes to patient compliance and trying to achieve that with this population, before surgery, it's very much non-compliant. I may counsel someone for 6 months and they will not lose a pound. I focus on behavior modification that's going to help them after surgery. If somebody makes no changes before they have surgery, they will wake up after surgery and feel like someone pushed them off a cliff, and that's uncomfortable for them. So I try to talk to them about that and give them that opportunity to start making these changes, whether it results in weight loss before surgery or not. I need you to eat your protein first, your vegetables second, minimize your simple carbohydrates. After surgery compliance, initially extremely important. If somebody advances their diet too quickly, most of the time they start off on clear liquids to full liquids to a softer pureed stage and then a regular stage. And people advance through that based on the surgeon's recommendations, and that they could be on a regular diet a month after surgery or not until 6 months after surgery. It's up to the doctor. If they advance too quickly, oftentimes we will see them brought back in for an EGD scope, possibly with a dilation. Sometimes it will cause their esophagus to stricture and close up, and you'll get the complaint of, I feel like I can't swallow anything. I feel like food's getting stuck, things are coming back up. So the surgeon has to go in, scope them, see if there's something wrong. They'll balloon dilate them sometimes. Occasionally, maybe 5 to 10% of the time, the surgeon will find something stuck. Believe it or not, it's not usually broccoli. Tends to be garlic bread, pizza. Sometimes it's a vitamin or a pill. We usually ask them to crush or cut medications or take chewable versions, and if they haven't done that, that can get stuck. But it's pretty obvious then if somebody's been non-compliant. And it's not, for me, it's not about shaming the patient. That's not going to get them anywhere. They have lived their life this way, overeaten and eaten these certain foods for probably 30 plus years. That's a lot to ask them to change. That's why we try and work on it pre-op. If they've chosen not to, and now we're working on it post-op, now I go at it from the side of, this is about safety. Do you want to be sitting in my hospital on a TPN line for a month? No, especially not with COVID going on. Can't guarantee insurance is going to pay for it. So I try to go at it from that way, as well as weight loss. when people aren't eating the right foods, and especially when they're not taking enough protein in, they'll sit there and go, well, so what? I mean, I'm still not consuming that many calories. But when their protein levels are too low, they just don't lose weight. And the weight that they are losing is their muscle mass. They don't look good. They don't feel good. They're mad about it. And so it's really important that you do have a dietitian who understands that, who can talk to them from that side. Of course, the physician can do it. Generally, they refer out because, you know, they have lots of patients to see and they may not have the time to sit there and do an hour-long counseling session. So again, that's why having these docs understand that you understand this and will help their patient is super important. Sorry, just looking through questions before we finish up. This one is, do our programs require pre-surgical weight loss, and do you have patients on a liquid low-calorie diet prior to surgery? So most of the surgeons that I work with do not give somebody a weight loss goal before surgery. I've been doing some virtual consults with a doctor out of California. He does, and I always ask the patients that, has your surgeon asked you to lose weight before surgery? I don't ever give them that goal because, let's be honest, if these diets and things had worked for them, they wouldn't be sitting in this office asking somebody to hack out part of their stomach. That's never anybody's first option. So again, I go from the side of behavior modification. All of the surgeons that I have ever worked with do pre-op diets. They tend to be liquid, full liquid, low fat, low carbohydrate. Some of the most strict ones are basically 5 protein drinks per day, and then some water, Crystal Light, and broth. Then you get people who are a little more flexible, where they'll let them have full liquids that include milk, sugar-free pudding, low-sugar yogurt, sugar-free Jell-O, sugar-free popsicles, tomato soup. And then some surgeons do like breakfast and lunch a protein drink, and then dinner is a small meal that's like 4 ounces of protein, a cup of vegetables, maybe a little bit of olive oil for fat. So those would be kind of the various pre-op diets that I've seen. And again, that's at the surgeon's discretion. Oh, this is a good one. Somebody wants to know about ERAS guidelines, which is enhanced recovery after surgery, I think. That's new. That's something I've never worked with until I've gotten to this this facility. And so this past week, I've actually been helping my nurse go through that data. She did that was her QI project. You're required to do certain QI projects also for MBSA QIP. So it was interesting. Those sorts of protocols, I think each hospital is a little different with what they're trying to touch on for the ERAS protocol. A lot of the surgeons here are using it. There's a handful who still aren't. And so for us, we are doing pre-op. We are giving them nausea medications like Amend, Zofran. Some of them get gabapentin. Some of them get Celebrex. And this is pre-op, that when they come in for their surgery, they will dose them with these. And then some do some pre-op IV or PO Tylenol. Then intra-op, the surgeons are doing tap blocks. And then post-op, this is the piece where ours is a little bit, we're still working on it. A lot of the doctors here were using IV, PO, or PCA opioid pumps. And so that's really what she's been looking at, is trying to see nausea level and pain level post-op based on what we're doing before surgery and what we're doing after surgery. By adding the Amend in, Amend is a medication, or a Prepertant is the generic formula. That's a medication that was developed for oncology patients who are undergoing chemotherapy because they get a lot of nausea. It covers you for about 3 days. Like if you take it, it's in your system for 3 days. So by adding that in, we have seen our nausea level go from like patients reporting a nausea level of 4 down to 0.5 is the average. So that is very clear that adding that in is helping with that, because all bariatric surgery patients initially report nausea. Pain level we're also looking at. Obviously, pain is perceived differently by every person. But it's very interesting. The patients who, and of course we're pulling the information from the chart, and the nurses always ask what your pain level is reported. So it's patient reported pain level. And so my coworker was pulling this information always, when it data, you have to use the same data point. So it was always at 8 a.m. or 7 a.m. when the shift changed, what the patient reported their pain level as. So that's where we got that number from. And then I was pulling out of the chart what meds they'd been given. We were not counting PACU. Of course, people get fentanyl and things when they're coming out of surgery, but we're counting it once they get up to the unit, what they've been given. So some surgeons who are doing ERAS, they are not giving opioids unless, I mean, it's there in reserve. If a patient is dying in pain, of course you're going to give that. But generally, we have one surgeon in particular who's using that, and he is giving gabapentin and Zofran, usually for nausea. Some of the patients are getting Celebrex post-op, which I know can be controversial. That's an NSAID medication, and some surgeons won't give that once somebody's had bariatric surgery. So as I was pulling this data and compiling it and averaging it, the patients who were on PCA opioids and oral, any opioid medication, they report a higher pain level than the patients who are not on anything or who are on just PO Tylenol. So yeah, it's fascinating. So yeah, our time is up here. But if you want to contact me, Danielle Houston, it's spelled like Houston, just like the city in Texas. I have a personal Facebook, of course, where you're welcome to message me or connect with me. I don't have any professional channels right now. And I'm on Build Up Dietitians, Build Up Dietitian's Body group as well. So yeah, if you guys want to reach out, if you're trying to get into bariatrics or you're overseeing a program, I do have a lot of knowledge through the years with the different ones that I've worked with. So I'm always happy to connect and help. I think that's super important for our patients and for dietitians to connect and know each other. So I really appreciate it, and hopefully I'll get to talk to you some guys soon.